So we are continuing on here with chapter 18, which covers all of the gram-positive cocci. So I'm going to start off with the staph genus. So staphylococci mostly are common inhabitants of the skin and mucous membranes. They are arranged in a staph multicellular arrangement, so this is grape-like clusters. They do not have spores or flagella. They may have capsules, and there's over 30 different species within this genus. So remember, coccus single cell, gram-positive, so they appear purple following the gram staining protocol, and they are arranged in a staph irregular cluster arrangement. Now, specifically, Staph aureus is found within the nasopharynx and the skin. And pathogenic forms of this microbe produce many different virulence factors. So please make a note when we are talking about Staph aureus and also Streptococcus pyogenes. There's a long list of different virulence associated factors. So please make sure to remember these. So for Staph aureus, many different enzymes can be found within some of these strains. Everything from coagulase, which functions to coagulate plasma and blood. It's produced by 97% of human isolates. Also can be used as a diagnostic enzyme. So if we have staph species, specifically the aureus species will have coagulase. All other staph species are coagulase negative. Now, hyaluronidase also is another enzyme that is found within this specific genus species. It will digest connective tissue or hyaluronic acid. Staphylokinase will digest blood clots. Also, these strains may express DNase, which will metabolize DNA, lipases, which break down oil, and penicillinase, which is a mechanism for antibiotic resistance, which will inactivate penicillin. And go figure, we have a lot of antibiotic resistance associated with Staph aureus. So MRSA is a big one. We're also seeing VRSA. Now, as far as the second group of virulence factors, so we have enzymes as the first. Second would be toxins, everything from hemolysins, which will function to lyse red blood cells, to leukocidins, which will lyse neutrophils and macrophages. Also potentially exfoliative toxin. So in the case of scalded skin syndrome, this toxin will function to separate the epidermis from the dermis. Also, cases of food poisoning show expression of enterotoxins, which will induce GI distress, or even TSST, which is toxic shock syndrome toxin, which can induce fever, vomiting, shock, systemic organ failure, and can lead to death. Now, there is a way that you can screen for staph strains on blood agar, looking for the presence of these zones, similar to the Kirby-Bauer disc diffusion test, where you're looking for the clearing around the disc. Here, you would look around the colony and see the clearing of beta hemolysis, or lysis of red blood cells caused by the production of an alpha toxin or a beta toxin. Now, most of these strains here, again, are found in the nose, skin, or the intestines, and the carriage rate is actually anywhere from 20 to 60%. It can be readily isolated from fomites or inanimate objects frequently, and the predisposition to infection includes everything from poor hygiene and nutrition, tissue injury, pre-existing primary infection, diabetes patients, and also immunodeficiency. And as I mentioned before, there is an increase in antibiotic resistance. So staph bacteria can cause many different types of infections. So everything from localized to systemic. As far as localized, these are the different varieties of a localized skin infection. And these bacteria can enter through breaks in the skin, through hair follicles, or also through glands. So folliculitis would be more of a superficial infection of a hair follicle, usually resolved with no complications. can progress. In the case of a furuncle, this is also commonly known as a boil, where you have infection of the follicle, or the sebaceous oil-producing gland, which progresses to an abscess or a pustule. And then we have deeper in the skin a carbuncle, which is larger and a deeper lesion created by an aggregation and interconnection of a cluster of boils. Also, impetigo or impetigo, we're going to see this associated with streptococcal bacteria as well. Please remember, in the case of staph, it's called impetigo. In the case of strep, it's called pyoderma. So this particular infection is characterized by bubble-like swellings that can break and peel away and crust off from the surface of the skin, most common in newborns, and it is easily spread, so it's highly contagious. So here's just some images here on the left showing you cartoon image of an infected hair follicle, and then on the right top you're seeing a furuncle, on the bottom a carbuncle. So again, these are deeper and they result from multiple interconnecting furuncles. Now, staph bacteria can also cause a systemic infection. In the case where it's spreading to the bone, this is known as osteomyelitis, and an abscess internally will form, or bacteremia, which is bacterial infection of the blood. So in this case, the primary origin is bacteria from another infected site or medical device. This can progress to a more serious infection of the heart. So this is cartoon image within the long bone showing you staph cells, and this can make the bone very weak, so more prone to breaks. Now, staph bacteria can also cause food poisoning or scalded skin syndrome or toxic shock syndrome. So in the case of food poisoning, you would have to ingest the enterotoxins associated with staph bacteria. This causes GI distress. We also have staphylococcal scalded skin syndrome. So this exfoliative toxin that I mentioned before would be expressed in this case, and this would induce a bright red flush, blisters, and separation of the dermis from the epidermis. Also, toxic shock syndrome is caused by staph bacteria, and this will lead to the production of TSST in the blood, leading to shock and organ failure if not caught early. So this is the scalded skin syndrome case here, and you can see a histology micrograph on the bottom showing you the actual separation of the epidermis from the dermis. Now, some other species worthy of mentioning here, and all of these are again coagulase negative, so it's only coagulase positive Staph aureus. But all of these staph, epidermidis, hominis, capitis, saprophyticus, these are associated with potential wound infections by penetrating through broken skin. And the last one here, saprophyticus, we see causing urinary tract infections. So this is another causative agent of UTIs along with E. coli and a few others that we will see in chapter 19. Now, as far as identifying staph in patient samples, we could set up a coagulase test to look for Staph aureus. Again, Staph aureus would be coagulase positive. Also, all staph are catalase positive. Try and grow it, right, in culture. And in the case where you're trying to diagnose a patient infection, you would look for this bacteria in pus, tissue, exudate, sputum, urine, or blood, depending upon the nature of the infection. Now, Staph aureus cases, 95% have that enzyme that can chew up penicillin or are resistant to a closely related antibiotic, ampicillin. We also see a lot of methicillin resistance, and many strains carry multiple resistance. So in the case of wound infections, more serious abscesses would have to be surgically perforated, and in the case of osteomyelitis or some of the bacteremia, sepsis, more intensive lengthy therapy, multiple antibiotics may be required. Now, as far as preventing staph infections, especially in the hospital environment, hygiene, cleansing, universal precautions by healthcare providers is essential. Now, moving on from staph to strep. So strep again is gram-positive, but it's now in chains rather than clusters. So for these bacteria, they do not have catalase, and they also do not have coagulase. They're generally smaller as far as the macroscopic array of colony formation. There's around 25 different species of these bugs. So again, it's gram-positive, it's a coccus, and it's in the arrangement of a chain or a strep arrangement. Now remember, Rebecca Lansfield was an early microbiologist that worked with this bacteria, and she was successful in determining the different cell wall antigens associated with many different species. So this was known as serotyping based on those different groups. Now, another classification of strep bacteria is based on the types of hemolysins that they produce, so the beta hemolysin or the alpha hemolysin. In the case of alpha hemolysins, this is produced by Strep pneumoniae and other strep bacteria collectively referred to as viridins. The rest usually express beta hemolysins. So we're going to talk about these 5 different pathogens. In the case of the viridins, it's a different group, or collectively a group of strep bacteria. So strep pyogenes, strep agalactiae, the viridins, strep pneumoniae, and Enterococcus faecalis. So strep pyogenes is the most serious streptococcal pathogen. It is found in the throat, the nose, occasionally on the skin, and it can cause a few different types of infections. So similar to staph bacteria, strep pyogenes has a long list of virulence factors. So these surface antigens include C carbs, so these work to protect against lysozyme. Also M protein, which can vary from strain to strain. This contributes to resistance to phagocytosis. Also, the fimbriae on the surface of the cell assist in its ability to adhere to the target tissues. Also, hyaluronic acid capsule on the surface of the cell, which will work to provoke no immune response. And this is the picture here just showing you cartoon image of the M protein that I mentioned that's variable from strain to strain. Also C carb, fimbriae, capsule, those are all very important virulence factors. So along with the cell wall antigens, we have a list of toxins. So streptolysins, SLO and SLS, both can cause cell and tissue injury. Also pyogenic toxin, or also known as erythrogenic toxin, which will induce fever and a red rash. And then possibly super antigens, which will cause the release of TNF-alpha, or tissue necrosis factor. And this is produced in response to an increase in inflammation. So this is similar to a cytokine or an inflammatory molecule that is produced during the course of an infection. Now we also have a list of enzymes like we saw with staph bacteria. 2 of these are redundant with staph bacteria, so the hyaluronidase, the DNase. We also have streptokinase. And it's worthy to note here that one disease that's associated with strep pyogenes is necrotizing fasciitis. So this is literally a disease where the bacteria will eat away at the flesh or eat away at the skin. And once this happens, this is irreversible damage. Sometimes people require amputations as a result of the breakdown of the tissue. Now, as far as transmission of this bacteria, contact, droplets, food, fomites, the portal of entry is generally the skin or the throat. And children are the predominant group affected for both skin and throat infections. Cases where this bacteria cause systemic infections can lead to longer-term effects on specific organ systems if left untreated. So, for example, For skin infection, so again, this is streptococcal bacteria. Remember I said along with staph, it can cause impetigo, but in this case, it's known as pyoderma. So same symptomatology here, superficial lesion that will break and it forms this highly contagious crust. It's often occurs in epidemics in school children and associated with additionally insect bites, poor hygiene, and crowded living conditions. Strep bacteria can also cause what's known as an erysipela. So this is when the pathogen will enter through a break in the skin and spread deeper to the dermis. And you can tell in the case of erysipela, this red flush appearance to the face versus the impetigo you see on the left-hand side. Also, strep bacteria can cause strep throat. So strep throat, specific medical term here would be pharyngitis. This is caused by streptococcal pyogenes bacteria associated with inflammation, swelling of the throat, so difficulty swallowing, usually a pain associated with it, redness, tenderness. Now, also, strep pyogenes can progress to scarlet fever. So this would be kind of the secondary stage of strep throat. So strep pyogenes in this case would be carrying a prophage that codes for an erythrogenic toxin. And if it's not scarlet fever, this may also infect the bloodstream. So strep bacteria can cause sepsis or even pneumonia or toxic shock syndrome as well. Now, group strep A infections can cause rheumatic fever. So this would follow subclinical throat infection in children, can spread to the heart, and can cause arthritis, fever. Heart valve damage is possible. It also could affect the kidneys. So it would cause acute glomerulonephritis, which usually is associated with increased blood pressure, occasionally heart failure, and can become chronic, leading to kidney failure. The Streptococcus agalactiae, this is the one that can be transferred to the infant during delivery and can cause severe infection. So pregnant women should be screened and treated. This is the most common prevalent cause of neonatal pneumonia, sepsis, and meningitis. It's normally found in the human vagina, the throat, and the large intestine. And also, not only can it be transferred to the infant during delivery, causing these types of infections, but also can infect wounds and can cause heart infections in immunocompromised individuals. We also have a couple other groups here, so group D, C, and G, strep. So the enterococcal bacteria are found in the large intestine. They can cause a variety of opportunistic infections. We also see groups C and G, which are common animal flora and can cause kidney, throat, and blood infections. So how do we identify strep bacteria? Remember, it is catalase negative, and also it has these C carbs. So this rapid diagnostic test is based on an antibody that reacts with the C carbohydrates. Positive reaction in the bottom here. Also, you can set up a CAMP test and look for the ability to hydrolyze esculin. So all of these specific tests could tell you what species you're working with. So if you know it's strep bacteria, if it's bacitracin sensitive, you have strep pyogenes. If it's bacitracin resistant, then a variety of tests will tell you whether you have Agalactiae or other species present. Now, as far as treatment schemes, groups A and B are treated with penicillin, long-term penicillin for people with a history of rheumatic fever or recurrent strep throat. And the enterococcal infections usually require a combined therapy regimen. Now, the viridins collectively include Streptococcus mutans and a bunch of associated oral bacteria. So a lot of these are found around the teeth, the gums, the oral cavity, also the throat, genital tract, and skin. And in the case of dental procedures, if there is a cut in the mouth, these bacteria can enter through that specific cut, spread to the bloodstream, and then attack the heart. So dental or surgical procedures can facilitate that entrance, and usually people are given prophylactics if they have pre-existing heart conditions. So in this case, for the viridins, the most serious infection would be subacute endocarditis, where the bacteria finds its way to the bloodstream and settles and grows on the heart lining or valves, and especially people with pre-existing heart disease are at the highest risk. And in this case, the strep bacteria will form a biofilm. Now, these bacteria could also cause meningitis, an abdominal infection, and tooth abscesses as well. So for anyone who has had a cavity or will develop a cavity in the future, Streptococcus mutans is the causative agent of dental caries. So it forms the foundational layer of a biofilm on the surface of the tooth, and it's the basis for plaque. People with pre-existing heart conditions should receive prophylactic antibiotics before surgery, as I mentioned before, dental procedures, to prevent these bacteria from spreading to the blood and to the heart. Now, Streptococcus pneumoniae is the causative agent of pneumonia in 60 to 70% of cases. And these bacteria lack catalase and peroxidases and require these special growth-enriched conditions. So it requires blood or chocolate agar, and the growth seems to be improved by increasing the amount of carbon dioxide. Now, the thing to remember about strep pneumoniae is that it has a large capsule. This is the major virulence factor. There are 90 different capsular types that have been identified, and again, it causes pneumonia and also ear infections. 5 to 50% of all people carry it as a normal flora in the nasopharynx. And what we see is that usually young children or the very old or immunocompromised will develop infections associated with this bug, especially for geriatric patients who aspirate their food. So rather than swallowing their food, they inhale their food, it goes down the wrong pipe, and it will settle in the alveoli or the inner air sacs of the lungs. It also could lead to an ear infection. Now, as far as diagnosing cases of strep pneumoniae, the Quellung test can be conducted. This is a characteristic test that's used to look for the presence of a capsule, also the presence of alpha-chemolysin, sensitivity to aptotion, bile solubility, and the ability to ferment inulin. Treatment with penicillin GRV. We do have vaccines available, but we do see that there is an increase in the associated antibiotic resistance for this strain. And then we have the Neisseria genus. So we are going to cover gonorrhea and meningitis. So for Neisseria, they have capsules. They also have pili. And now we're actually changing over here from the gram-positive coccus to the gram-negative. So because it's gram-negative, it will have that pilus structure that will allow it to facilitate bacterial conjugation, so it can swap pieces of DNA, segments of DNA, and these bacteria produce catalase, and they also require enriched complex media. So the first species that you should be aware of is Neisseria gonorrhea. This is the gonococcus, causes this common STD. And you should remember there are two very important virulence factors associated with this pathogen, the fimbriae, which are on the surface that will allow for adherence or attachment, also inhibition of phagocytosis, and this enzyme that cleaves an immunoglobulin A. So this is produced in response to an infection and it will actually chop that antibody up, so it is no longer effective. So gonorrhea is in the top 5 STDs, and the ID is 100 to 1,000. It does not survive more than 1 to 2 hours on fomites, and cases have gone way down over the years, although we are seeing a lot of cases of antibiotic-resistant strains. Now, as far as symptoms in males, urethritis, yellowish discharge, scarring, and infertility, 10% of men do not show symptoms. For women, vaginitis, urethritis, and more serious case here of an infection when it affects the fallopian tube, so this is known as salpingitis. And there are cases of women who are infected, co-infected with the causative agent of gonorrhea and chlamydia, and this is called PID, or pelvic inflammatory disease. And this is a common cause of sterility and also ectopic or ectopic tubal pregnancies. 50% of women do not show symptoms. Also, in the case of a pregnant woman who is infected with Neisseria gonorrhea, they can infect the newborn as the newborn passes through the birth canal. So this can lead to eye inflammation and potentially blindness. This can be prevented by prophylaxis immediately after birth. Now, as I mentioned before, there are a lot of new antibiotic-resistant strains that we're seeing. So 20 to 30% of new cases are either penicillinase producing or tetracycline resistant. Combined therapies could be indicated. Also, recurrent infections can occur. And as far as diagnosing it, Gram stain and look for the presence of this bacteria in urethral, vaginal, cervical, or eye exudates. Now, lastly, we have the causative agent of meningitis. This is also known as the meningococcus. And we have, again, the Fimbriae and IgA protease, but we also see an endotoxin and capsule as well, which is critical for the pathology of this infection. There are 12 strains. Serotypes A, B, and C cause most cases. So it is a prevalent cause of meningitis. In humans, we find this bacterium in the nose and the throat. 3 to 30% of people will carry it normally. And as far as it causing infection, high-risk individuals are those living in close quarters, children 6 months to 3 years, also young adults 10 to 20 years. And this type of infection has a very rapid onset, also neurological symptoms, and the presence of the endotoxin causes bleeding and shock and can be fatal. So very important to diagnose, catch it, and treat people who have been around the infected individuals. So the bacteria will enter the bloodstream, cross the BBB, the blood-brain barrier, permeate through the meninges, and grow in the cerebrospinal fluid. So it's best to look for the presence of this bacteria in the CSF or the blood, or even in a nasopharyngeal sample. Look for the capsule and treat these infections with penicillin or cephalosporin, and also treat family members, medical personnel, or children who have been in close contact with the patient. We do have a primary vaccine that is available for this type of an infection. All right, so that completes chapter 18.